بسم الله الرحمن الرحيم أبناء طلاب الفرقة الثانية. We will talk about differential diagnosis of abdominal mass in this lecture. First, we should revise some anatomical consideration that will be helpful to us. The abdomen is divided into 9 anatomical regions by 2 vertical lines and 2 horizontal lines. The 2 vertical lines are the right and left midclavicular line. Midclavicular line pass from the midpoint to the clavicle to the mid-inguinal point longitudinally. The 2 horizontal lines, the inferior one passes between the 2 iliac tubercles, which is an elevation on the iliac crest behind the anterior superior iliac spine and called intertubercular line. The upper line passes by the plane of the pylorus of the stomach and is called transpyloric line, and passes between the tips of the 9th costal cartilage on both sides. These 4 lines divide the abdomen into 9 anatomical regions from the right to left: the right hypochondrial region, the epigastric region, the left hypochondrial region, the right lumbar, the umbilical and the left lumbar region, the right iliac fossa, and the hypogastric and left iliac fossa region. Also, we can divide the abdomen into 4 quadrants by 2 lines: vertical midline passing through the umbilicus and horizontal line passing through the umbilicus, to divide the abdomen into right upper, right lower, left upper, and left lower quadrants. The abdomen contains the stomach, duodenum, small and large bowel, liver, gallbladder, spleen, pancreas, kidney, ureters, bladder, aorta, and vena cava, and in females the uterus, ovaries, and fallopian tubes. All these structures are included together within this small abdominal cavity. The upper part of the abdominal cavity and also the lower parts are covered by bones that make the organs located in these areas inaccessible to palpation, being hidden behind the lower ribs or inside the bony pelvis. Next step is examination. And firstly, how to prepare a place for proper examination. The environment at first. The examination room must be warm and private, not exposed to others, and should have a good light. The best is the daylight coming obliquely on the body of the patient from a side window. The examination couch or bed must be hard couch with a backrest that can be raised by 15 to 20 degrees, like we see in the photo, like this. This position gives us the most suitable position for examination. We have a problem when the patient lies flat, the abdomen is opened. What I mean, the distance between the bones above and the bones below, the costal margin and the symphysis pubis, this distance is opened, so we can access the abdominal organs more better. But in this position, the anterior abdominal wall muscles are stretched and put in uh, attention, and this make examination not productive well. So to obtain a compromisation, we elevate the backrest of the examination bed to relax the abdominal muscles and keep the distance open between bones above and bones below. The patient should be exposed or uncovered from the nipple line to the knees. However, this may be embarrassing to patients, so we compensate by placing a sheet over the lower part of the abdomen till finishing the examination of the upper part of the abdomen and elevating it during examination of the lower abdomen and genitalia only. A very important step in preparation for examination is to get the patient relaxed on the examination bed. This can be achieved by the following tricks. Ask the patient to rest their heads on their head on the couch, their heads on the couch, or below to avoid tensing the rectus abdominis muscle. Ask the patient to place their arms by their sides, not behind their heads. This makes the abdomen more relaxed. Encourage the patient to sink their back into the couch and breathe regularly and slowly. This also relaxes the anterior abdominal wall muscles. Only press your hand to do your examination during expiration, where the abdominal muscles are relaxed during the phase of expiration. If the above maneuvers don't work, ask the patient to flex their hips to 45 degrees and their knees to 90 degrees to place an extra pillow behind their head. These procedures tilt up the pelvis and reduce the access to the abdomen, but they usually relax the abdominal muscles. لو أنا بعمل examination والعيان تنس ومشدود والابdominal muscles not relaxed ومش قادر أحس الديب organs، في الوضع ده بخليه يتني الهيب joint 45 degree والني 90 degree. This position tilt the bony pelvis up and cause relaxation of the anterior abdominal wall muscles by shortening the distance between their 2 points of attachment, the ribs above and the bony pelvis below. The position of the examiner. The examiner's hands should be clean and warm with short nails. دي حاجات مهمة جدا. ما ينفعش إن أنا أعمل examination للعيان وأنا ضوافري طويلة، لأن ده هيبقى painful للعيان. وبرضه ما ينفعش أعمل examination وإيدي cold، لأن ده هيinduce contraction of the anterior abdominal wall. The whole hand should rest on the abdomen by keeping the hand and forearm horizontal in the same plane as the front of the abdomen. أنا بنزل بالهاند والforearm للليفل بتاع الانتيريور ابدومينال وول، وبقرب من العيان بحيث ان الايز بتاعتي تبقى على مسافة 50 سنتيمتر من الانتيريور ابدومينال وول، وبالتالي ابقى شايف اي فاين asymmetry في الانتيريور abdominal wall. الكلام ده could be achieved only لما أقعد على كرسي جنب العيان أو أوطي جنب العيان، يبقى sitting on a chair or kneeling beside the examination bed during the examination to achieve this position. ده بيبقى optimum إن أنا أعمل examination بدون ما أعمل hurt للبيشنت. إنما لو عملت examination وأنا واقف standing هيبقى الإيديا هتبقى كأن هي نازلة بزاوية على الانتيرو abdominal wall، وبالتالي البالبيشن هيبقى harmful للبيشنت. نبدأ في الإكزامينيشن. والإكزامينيشن of the abdomen should pass through the 4 classical steps, which include inspection, palpation, percussion, and auscultation. At first inspection is done from the side of the patient and from the foot end of the table. During inspection, I should inspect the contour of the abdomen, vertical contour from the side and horizontal contour from the foot end of the table, to observe any asymmetry of the contour, the fullness of flanks, any distension, the costal angle, or at the same time the reverse to see if the abdomen is scaphoid, and so on. Normal abdominal contour بيبقى flat with a slight elevation في السوبرا pubic region، والفلانكس بتبقى concave. Also I inspect the skin for any scars, for hair distribution, for any pigmentation, and so on, and for any dilated vein that may indicate either portal hypertension or occlusion of the inferior or superior vena cava. I inspect also for pulsations, any visible peristaltic movements, and inspect for any mass that appear in the contour of the abdomen. Inspection of the mass. At first, I confirm the position of the mass. Is it intra-abdominal? Is it anterior to the abdominal wall? I mean in the skin and subcutaneous region, or arising from the abdominal wall muscles. This can be confirmed by the test that we see in this photo when we ask the patient in this position to elevate the head and the shoulders. This will induce contraction of the abdominal muscles. This contraction will mask the mass and make it less prominent if it is intra-abdominal, and will make it more prominent if it is anterior to the muscle in the subcutaneous plane, or no change will occur to the mass if it is arising from the abdominal wall muscles. Inspection of the mass, like this mass. This is a mass in the upper part of the abdomen, mainly epigastric and right hypochondrial region. This mass causing downward shifting of the umbilicus. I comment about the site, size, shape, surface, skin over if the mass is pulsating or not, its margin ill-defined or well-defined, if it moves with respiration up and down, and if there is any impulse during coughing regarding masses at the sites of hernial orifices. I also inspect the umbilicus for its position, shifted up or downward or to one side, everted or inverted, its color, any nodules or discharge coming out from the umbilicus. In this photo, we can see a nodule in the umbilicus. Also, we inspect the hernial orifices, like the area of the groin, to while the patient at rest and during coughing to detect if there is any hernial swelling. Palpation of the abdomen, the next step after inspection. Palpation, we should palpate gently but deliberately, firmly and purposeful. مش جاست ان انا امشي ايدي على الابدومن كده في اي اتجاه بحذر، لا انا لازما يبقى لي intention while I am moving and pressing my hand and trying to detect the deeper organ. Palpation have two types, superficial palpation and deep palpation or organ palpation. Superficial palpation mainly concerned to detect any tenderness and to detect the temperature by placing the back of the hand over the anterior abdominal wall and test the temperature, comparing it with other parts of the body. Tenderness is elicited by gentle, firm pressure on the anterior abdominal wall, passing for right-handed examiner in a circle anti-clockwise, starting from the left iliacosa, going up and rotating anti-clockwise to examine all the regions of the abdomen. Also, during this superficial palpation, we can indicate the presence of a mass in any of the anatomical regions of the abdomen. Palpation, specific palpation for any mass like this mass, should be the abdomen. The whole abdomen must be carefully palpated for the presence, the position, the shape, the size, the surface, the edges, the consistency of any mass, and for the presence of fluid thrill, and percussed for resonance or dullness, and also palpated to detect if it is pulsatile or not. Next, we start to palpate the solid organs in the abdomen, starting by the liver. Palpation of the liver is achieved by placing your right hand transversely and flat on the right side of the abdomen at the level of um, at the level of the umbilicus, parallel with the right costal margin. Then ask the patient to take a deep breath. If the liver is grossly enlarged, its lower edge will move downward and bump against the radial side of your index finger. If nothing abnormal is felt, repeat the process after moving your hands upward inch by inch until you reach the costal margin. This is palpation of the right lobe of the liver. My hand transversely, on the anterior abdominal wall, parallel to the costal margin, going from below upwards, pressing during expiration, and waiting to receive the enlarged, the lower border of the enlarged liver during deep inspiration. And this is how to palpate the left lobe of the liver by the fingertips passing upward in the middle area of the abdomen. Palpation of the spleen. Place the fingertips of your right hand on the right iliac fossa just below the umbilicus and ask the patient to take deep breath. If nothing abnormal is felt, move your hand in stages towards the tip of the left tense rib. الاتجاه بتاعنا من الرايت iliac fossa بالفينجر tips towards the tip of the left tense rib. When the costal margin is reached, place your left hand around the left lower rib cage and lift the lower ribs and the spleen forwards as the patient inspires. This maneuver occasionally lift a slightly enlarged spleen for enough forward to make it palpable. احنا عارفين ان النورمال سايز سبلين not palpable، وعلشان السبلين يعدي الكوستال مارجن ويبقى palpable abdominally محتاج إن السايز بتاعه يزيد 2.5 أو 3 ضعف النورمال سايز. في بعض الحالات المايلدلي انلارجد سبلين مبقدرش أحسه والعيان نايم فلات، فبضطر أحط إيدي الشمال behind the lower ribs and pressing anteriorly. This make the spleen to come anteriorly and can be palpated by right hand. Palpation of the kidney. To feel the patient's right kidney, place your left hand behind the patient's right loin between the 12th rib and the iliac crest so that you can lift the loin and the kidney forwards. Then place your right hand on the right side of the abdomen. For the left kidney, lean across the patient. Place your left hand around the flank into the left loin and lift it forwards. Then place your right hand on the abdomen. As the patient breathes in and out, palpate the loin between both hands and feel any mass between the two hands. دي الطريقة اللي بنحس بيها الكدني. Anterior hand و posterior hand والاتنين compressing و during deep inspiration kidney descend down. If it is enlarged I can feel it between my two hands. Normally the kidney is not palpable, but it may be felt in very thin individuals or if it is enlarged. If I feel the kidney easily, it is either enlarged or ectopic kidney descending in the iliac region. Next step during examination is the percussion. Percussion will complete my data that I have obtained by inspection and palpation. For example, the upper border of the liver cannot be palpated because it is hidden behind the lower ribs. So I detect its site by doing percussion in the intercostal spaces like this to reach the dull interspace where the upper border of the liver is located. Also in this photo I do palpation of the renal angle. Renal angle is made by the erector spina muscle vertically constrictor spina muscle and by the last rib horizontal. Last rib horizontal. This is the angle. Its palpation is like so to detect any tenderness or any swelling. And here we percuss the renal angle. Normally the renal angle is resonant for percussion. It will be dull when the kidney is enlarged and descend down. Also, I percuss for the lower border of the liver, for the spleen, and for any mass detected during palpation. I percuss to find if this mass is dull or it has a band of resonance. If it is related to the bowel, like mesenteric cyst, we will find a band of resonance. If it is enlarged kidney, we that push the ascending or descending colon forwards, I will detect a resonant band across the swelling vertically. Here we percuss for ascites to detect if there is free fluid in the abdomen or not by percussion from the central part of the abdomen down to the flanks to detect the level of dullness. Then fix my hand and ask the patient to tilt on the other side, keeping my hand in place, and then percussing again. If the note changed from dull to resonant, this indicates there was a fluid and moved by changing the position. This test is called shifting dullness test, done specifically for done specifically to detect free fluid in the peritoneal cavity. Auscultation as a fourth step of examination, we auscultate the abdomen to hear the intestinal sounds. The intestinal sounds are gurgling sounds, result from the passage of fluid and gas through the lumen of the bowel from part to part. Usually, this sound is low-pitched and is repeated every few seconds. Every few seconds. If the bowels are dilated, so it contains more gas and more fluid, this will make the gurgle sound or the intestinal sound high pitched and loud. If there is mechanical obstruction, the intestinal sounds will be more frequent than usual. I also auscultate for any vascular puree that result from partial stenosis or narrowing of the lumen of a large vessel in the abdomen, like the renal vessel. When it is stenosed, the passage of blood through it during each systole result in a sound that I can auscultate it by the stethoscope. Also, I auscultate for gastric dilatation called succussion splash when the stomach is obstructed at its outlet at the pyloric region. Fluid and gas accumulate in the stomach and the stomach dilate. When I make shaking of the abdomen of the patient while the stethoscope is placed over the gastric region, I will hear the sound of shaking the fluid and gas in the dilated stomach. This sound is called succussion splash. During abdominal examination, we should take care never never forget to examine the following items: supraclavicular lymph glands, hernial orifices, femoral pulses, genitalia, bowel sounds, and anal canal and rectal examination. All these will complete my abdominal examination because it will give a data that help in diagnosis and may be lost if I skip these items during the examination. How to differentiate differential diagnosis of an abdominal mass detected in the abdomen. Back again, let us think anatomically where the mass is located regarding the 9 anatomical regions of the abdomen because contain contain specific organs, and any mass in this region should arise from the organs located in this anatomical area. So, generally, different causes of abdominal mass may be gastric mass, may be pancreatic body mass, may be colonic mass, mesenteric or mental mass, carcinoma, cecum, appendicular mass, ileocecal tuberculosis, pelvic mass, gallbladder mass, or mass in the umbilicus, or arising from the liver. So what is the differential diagnosis of a mass in the right hypochondrial region? I can hear you saying what are the organs in these regions to think about the differential diagnosis of a mass in it. The organs in these regions are the liver, so the mass may be arising from the liver. The liver itself may be enlarged. There may be a hepatocellular carcinoma causing nodule that felt like a mass in the right hypochondrium, or a cyst in the liver, or inflammation in the liver, or secondaries from malignancy in the GIT. The gallbladder itself may be the origin of the mass, as in cases of acute cholecystitis, mucocele or biocele of the gallbladder, or cases of cancer gallbladder. The mass may arise from the right hepatic flexure, as in cases of cancer or intussusception, may arise from the right kidney or right suprarenal gland. Mass in the epigastric region may arise from the left lobe of the liver, may arise from the stomach, transverse colon, body and head of the pancreas, and para-aortic lymph nodes may be enlarged, and there may be aortic aneurysm and giving us the mass in this area. Mass in the left hypochondrium, it may be arising from the spleen or the splenic flexure of the colon, may arise from the tail or body of the pancreas, may arise from the fundus of the stomach or body of the stomach, may arise from the left kidney or left suprarenal gland. Mass in the right iliac fossa may be appendicular mass or abscess, carcinoma of the cecum, ileocecal tuberculosis, and Crohn's disease of the terminal ileum, may be ectopic testis, may be ovarian swelling extending to the right iliac fossa or ovarian cyst, may be a tube ovarian abscess of the right side, may be lymph nodes or undescended testes. Mass in the left iliac fossa, maybe carcinoma of the descending or sigmoid colon, or diverticular disease, or ovarian, psoas abscess, ectopic kidney, maybe lymph node mass or undescended testis in the left groin as in the right side. Mass in the hypogastric region or suprapubic region may arise from the bladder, urinary bladder, may arise from the uterus like fibroid, or may arise from the ovary extending from the pelvic cavity into the abdominal cavity. Mass in the umbilical region may be arising from the mesentery of the bowel, like cyst or mass, may be omental, may be ovarian, with a long pedicle, may be a small bowel tumor, may be extension of masses in the surrounding anatomical region, or may be lymph node enlarged or retroperitoneal tumor. After examination of abdominal mass and collecting data regarding the history of the patient, we need to do some investigations to reach a proper diagnosis of the origin and pathology of this mass. During the previous show, we was thinking anatomically to reach the diagnosis. After reaching the anatomical organ affected by the mass, we should think pathologically to know the pathology of this mass. Is it inflammatory mass? Is it neoplastic mass, benign or malignant, and so on? What are the investigations needed? Laboratory investigations like CBC, liver and renal function tests, ultrasound examination of the abdomen, or endoscopic examination like upper and lower endoscope, contrast studies like barium meal and barium enema and follow through, CT and MRI examination of the abdomen, endosonography examination during endoscopic examination by ultrasound loaded on the terminal end of the endoscope, and to be more close to the organs, and this will give a very important and accurate data. Taking a sample from the peritoneal fluid, acetic tab, and investigating it, diagnostic laparoscopy, ultrasound or CT guided biopsy, and investigations on the urinary system like IVU or cystoscope or isotube renogram. And finally, we may not reach a exact diagnosis, and it is necessary to do exploratory laparotomy to reach the diagnosis and manage the condition. Thank you for your attention.